Hi, everyone. So this is our emergency preparedness class. So we're going to go over CPR, AED, allergic reactions, bleeding control, splinting, and environmental emergencies. And so, yeah, they'll just be short presentations on all of them, starting with Danielle and CPR.
Hi, everyone. Thanks for joining us. Super excited to share this little piece of BCEMS with you. My name's Danielle, and I'm a CPR instructor. So I'm just going to share with you a little crash course on bystander CPR. We do teach classes on campus, so if you're interested, totally check out our website, and that would be awesome. We have full classes where you can get certified to do CPR. So with that being said, I'd like to just start with some of the purpose of doing CPR. Obviously, a lot of us know that if somebody's unconscious and not responding, kind of the instinct that we're taught is like, oh my gosh, that person needs CPR. Well, sometimes if somebody's unconscious and not responding, they're asleep or they fainted or some other things could have happened. But when CPR is really needed is when somebody's heart stops. So one way that we check as EMTs and as certified CPR instructors or CPR providers is we check for a pulse. A lot of people will check for your pulse right here, right underneath your jaw, to the side of your trachea. So you can practice doing that on yourself. Sometimes in the heat of the moment, though, it's really hard to check that if you're not trained to do it. So when bystanders are taught to do CPR, if you haven't been trained officially, we just tell you, don't bother checking for a pulse. You should follow just a few important steps before determining that you think CPR is necessary. So the first thing is make sure that the scene is safe. Sometimes what happens is, maybe somebody was exposed to carbon monoxide, which you might not realize caused them to pass out and could be a danger to you as well. So just do a quick sweep of the area, make sure that nothing is of immediate danger before you hop in and try to give care to somebody else. One patient's always better than two. We don't want to make you into a patient as well. So make sure it's safe. And then you can approach the person and try tapping them on the shoulders, shout, ask them, are you okay? Are you okay? If they respond to that, awesome. They don't need CPR. That's really cool. But if they don't respond to that, you're going to want to call 911 because there's only so much that you can do hanging out there with your limited training. Even I would call 911 in that scenario. You call 911 and then you can ask somebody if somebody else is around to get an AED, which you'll learn about in the next little group. So call 911, get an AED, and then what you're going to want to do is just immediately start chest compressions. So I'm going to try to demo this as best as I can here on the table. So the table is my patient. Hello, are you okay? Are you okay? If I don't get any response, I'm going to take my phone, put it on speakerphone, call 911, and start doing chest compressions. So usually your person's not on a table, they're probably on the ground, right? So you're going to want to kneel next to them. Imagine my chair is the ground. You're going to kneel and you want your chest to be over the table, over your patient, and you're going to be on the side of them. So you can imagine that their head is right here and their feet are down on this end. And then you're going to take your hands, you can interlace your fingers if you'd like, or you can just lay them one on top of another. And you're going to take the heel of your hand, put it in the center of their chest, and push down with your body weight. Now, I'm on a table right now, right? So I can't exactly push down and make any significant difference on the volume of the table. But if someone was right here and that was their chest, I would push down. And what I'd actually be doing is squeezing their heart. Okay, so what you're doing is you're squeezing their heart to get the blood around their body because their heart has stopped doing that for themselves. So when I do that, I want to use my body weight. Notice how I'm not bending my elbows because I'm actually going to get tired really fast. Bring it back in. I'm going to get tired really fast and I probably won't push down far enough. Okay, just a couple little things to note. If you're doing CPR on somebody and they don't tell you to stop when you start doing compressions, they probably need it. So you're not going to actually hurt them. They're not going to feel it. So a lot of people will wonder, well, am I going to break their ribs? Am I going to hurt them? The short answer is it's way better to save someone's life and have them with a couple of ribs that are separated than to not try to save them the proper way, right? So don't be worried about pushing too hard. You want to essentially push hard and fast. Some of you, if you're fans of The Office, might know that you're gonna sing "Staying Alive" by the Bee Gees. So staying alive, staying alive. There's some other songs. Baby Shark is unfortunately a very catchy one, but fortunately, because it will not get unstuck from your head, that is another one that's really good. So essentially, what you're going to do as a bystander is just do those compressions until help arrives. We no longer recommend doing mouth to mouth unless it's someone that you're super, super comfortable with, especially in COVID times. But in general, let's say you have an allergy. You don't want to be doing mouth to mouth on somebody who might have been in contact with your allergen, or somebody who took drugs that you don't know what they took, or, it's COVID, right? We all wear masks for a reason. You don't want to just put your mouth on somebody else's mouth that you don't know where they've been and stuff. So we don't actually think from current research that that's going to be as effective as we once thought it was. And so we think that hands-only CPR is actually just as effective a lot of times when compared to hands-only CPR with mouth-to-mouth. So for your safety and for the fact that it's not going to make it any less effective, we're just going to do hands-only CPR until further help arrives. So I hope that you guys learned a little bit something today. Super happy to answer questions, but if this was interesting to you and you want to learn more, totally check out our CPR section on our website. Thanks so much.
Thank you, Danielle. If nobody has any questions, Juliana is going to talk about AED, which pretty much goes hand in hand with what Danielle just talked about.
That sounds great. So I'll just share my screen. I have a quick presentation ready. All right, so you should, oh, no, that's not what I want. Okay, so you should be able to see the slides now, right? Thumbs up if you can see them. Yep, okay, great. So, an AED, so let's go through it. Okay, so what is an AED? So it is an automated external defibrillator, that's what it stands for. It is used in emergency circumstances to revive a patient. So an AED works by sending an electrical shock from one pad to another, which electrically stuns the heart. The AED works to adjust current and voltage depending on resistance within the patient, so there's nothing you need to worry about in this case. Okay, so components of an AED. So as you can see here, most AED kits come with one pair of adult pads, sometimes one pair of child or pediatric pads, maybe infant pads as well, but those are pretty rare. The AED device itself, a manual, scissors or shears for cutting through clothing, a razor, exam gloves, and antiseptic wipes. All right, so what does an AED actually do? So it reads the heart rhythm of the patient. So most often this rhythm is known as ventricular fibrillation or VFib. So that's when the normal heart rate rhythm becomes irregular and is too short and too fast for enough blood to actually circulate through the ventricles. So there's also another case which is known as ventricular tachycardia. So, or it's also commonly known as Vtac. So this is when the heart rhythm is much faster than normal. So as you know, normal is around 80, sometimes around 100. That's beats per minute. That's pretty typical. In ventricular tachycardia, it's more like 150 to 180 beats per minute. And this does not allow for enough blood to be filling through the heart chambers. So in this case, the AED will sense that rhythm. So it's important to note that an AED will not restart a heart that's in asystole, which is a heart that has completely stopped beating, but rather it detects these irregular rhythms and will shock the heart so that it can go back into a regular rhythm, but it doesn't just completely restore the heart. All right, so when do you use an AED? So an AED is designed to be used when a patient is experiencing cardiac arrest. So if you're unsure whether or not the patient is in cardiac arrest, you don't have to worry about that. As Danielle kind of explained earlier, you check for pulse, check for responsiveness. Same thing applies here. If they are unresponsive and if they are pulseless, then you want to use an AED. And you also don't want to worry about hurting the patient, because I know sometimes when you see it or when other family members may see it, the electric can cause the patient to kind of jump up in the air, and that can be frightening if it's something you've seen for the first time. But you're not going to harm the patient. The benefit of using the AED is going to be far greater than whatever you may perceive is happening. And so for adults, you want to use an AED immediately, as soon as possible, because cardiac arrest is the primary reason that they're unresponsive, most likely. However, for children, it is likely that respiratory failure triggered the cardiac arrest. So you still do want to use an AED if one is available, but for children, doing CPR is the more important aspect. All right, so who can actually use an AED? So often you hear first responders and then EMTs like ourselves talking about using them, hospital staff, but you can also use it too. So if there's one available and you feel comfortable operating it, you should definitely take advantage of using it, because it can help to save the patient's life. So how do you use an AED? So it is pretty straightforward. You want to open the AED. As you can see, it's typically zipped up in a package, and you want to turn it on. Once you turn it on, there will be a prompt that guides you to how to use it. So each system varies a little bit, but it's good to just take the time and listen to kind of what it's saying. So you want to make sure that you put the pads of the AED directly on the person's skin. So that means you may need to remove any articles of clothing that they have, or wipe down their bare chest if it's wet. And after you do that, you can attach the pads, which I'll go over in the next slide where you want to attach those, but you want to put the pads on the skin. You want to make sure that nobody is touching the patient as you allow the AED to analyze the heart rhythm. If someone is touching the patient, like you or someone else, the AED will read your heart rhythm and will not send a shock, because it detects a normal heart rhythm from you. So you want to make sure that after you analyze it, if a shock is advised, that again, you are not touching the patient when you deliver the shock. And once the shock is delivered, you want to resume CPR immediately, so that the heart can get enough blood generating throughout the body, if it is possible, to kind of get their rhythm back to normal. Okay, so choosing and placing the pads. So like I mentioned earlier, there are typically two sets of pads that come in an AED kit. You'll see adult pads and pediatric pads. So for adults, they're considered anybody who weighs more than 55 pounds. So this is going to be most people you would probably encounter. And when placing the pads, you can see on the mannequin here, which is known as Annie, just kind of a fun little fact. You want to place one of the pads kind of just below, like the right clavicle area, and you want to place the other one on the left, below the left rib cage. And you just really, it's not as important that they're in the exact correct location. What's more important is that they're far enough apart to generate an electrical signal through them. And so children, they're considered to be anybody who is under 8 years old. And for those, there are pediatric pads that you can use and place on the front and the back of them. But a couple things to keep in mind. So if there aren't pediatric pads, you can always use the adult pads, putting them on the front and the back. And if for some reason you're not able to kind of tell, oh, they might be 9 years old or they might be 50 pounds, don't worry so much about that. You can use the adult pads because the AED will automatically be able to sense how much electrical shock is needed, because nowadays most of them are regulated to control the correct amount of electrical shock given based on the patient, because it can sense, I guess, like how much resistance the patient is giving it. So it's able to monitor whether or not it needs to provide a bigger or smaller electrical shock. So all in all, if you can't tell, just go with the adult pads. There's no harm. So a couple of special circumstances. So there could be a pacemaker or some other form of device in the patient. Sometimes it could interfere with the AED pad placement. Sometimes it could not. So if it does interfere with the AED pad placement, you cannot put the AED directly over any medical device. Doing so, it will damage the device, and it will also not send a shock efficiently from one pad to the other. It'll probably send it through the device, and then it'll be weakened, and then it just really won't work how it's supposed to. So you want to place it at least 1 inch away. Again, it doesn't have to be an exact measurement, just far enough away that the shock won't go directly through it. Some other special circumstances would be a transdermal medication patch. So this is typically nitroglycerin, which actually does help to monitor different heart circumstances. So if the nitroglycerin patch or whatever transdermal patch is in the way of the AED, of where you place the pads, you want to take it off and wipe down the chest so there's no residue left, because if the patch was there, the electrical signal wouldn't go through from one pad to the other, but instead it would burn the skin of the patient, which is definitely not what you want. And then 2 other circumstances could be a wet patient and a hairy patient. So for a wet patient, if they're submerged in a puddle or in a big area that's kind of all wet around them, you want to either pull them out of a puddle, or what's more important is that you quickly dry their chest. You don't want to take a ton of time doing this, but you want to make sure that they're dry enough so that the electricity runs through the pads and not through the water, again, causing burns on their skin, which is not what you want. And then for hairy patients, you want to make sure you shave the area of the chest where you're putting the pads, because they won't stick if you just put the pad directly over the hair. Again, that would burn the skin because the electrical current isn't being sent through the pads, but it's rather on the surface of the skin. So there is a razor provided in most AED kits. You don't want to spend a ton of time doing this. You want to use the AED as quickly as possible. But just to do kind of a quick clearing of the area, either a quick wipe down of wet skin or a quick shave, just enough so that the AED can work properly. Okay. And so overall, the goal of the AED, you want to achieve ROSC, which is known as return of spontaneous circulation. So this means that the heart is electrically shocked back into the proper sinus rhythm. So it'll allow for the heart to once again pump and the patient to kind of come back to life. So if any of you guys have any questions, feel free to ask, but otherwise, thank you for listening to the presentation.
Okay, thank you, Juliana. That was really good. If anybody has any questions, you can either ask now or ask at the end if you don't have any now, and if nobody has any, Bridget will be next.
Hello, everybody. I'm going to give a quick presentation on allergic reactions. I'm just going to pull up the presentation right now. Can people see my screen? Fantastic. All right. So what is an allergy? Many of you probably know people that have allergies, but the Oxford English Dictionary describes an allergy as an altered immunological reactivity to a foreign antigen following a previous exposure to it. Later, it's used to describe an abnormal form of such a reactivity or a hypersensitivity, which causes damage to tissue and results in disorders such as hay fever, asthma, eczema. And more widely, allergy is used to describe an intolerance of or an adverse reaction to a specific substance. So in summary, an allergy is a hypersensitive immune response to a specific allergen, to a specific thing in the environment. Your immune response works to protect your body from the environment, like with germs or if you break a bone. But an allergy is a response to something that from the environment that wouldn't usually warrant such an immune response. Anaphylaxis is probably one of the most serious reactions to an antigen, and we're going to talk about that later. But it's important to know that you can have an allergy without going into anaphylaxis. So what are some common allergens? First of all, I really just wanted to include a picture of my dog. This is my dog, Dory. I don't know if you can see my mouse, but she's in the upper right-hand corner. Because a lot of people have allergies to animals. People have allergy to pollen, different medications, such as penicillin's a common one, latex, poison ivy, peanuts, dairy, shellfish, gluten, you name it. Most people that you interact with are probably going to know their allergies. And if you ask them, or if they're starting to feel ill and you ask them, do you have an allergy? What do you have an allergy to? They're likely going to be able to tell you. One thing to maybe look out for is bees. If people have never been stung by a bee before, especially if they have allergies to other things, they might not know they have an allergy to bees, but they might react adversely. So be on the lookout for bees. So as I said earlier, anaphylaxis is a serious reaction or a serious response to an allergy. Some symptoms of anaphylaxis are feeling lightheaded or faint, having breathing difficulties. So the person might be breathing fast and shallow. They might be wheezing, have a fast heartbeat, clammy skin, confusion and anxiety. They may collapse or lose consciousness, which would be the worst case scenario, and hopefully we'll be there by that time. They may have low blood pressure, develop hypoxia, which is just a fancy word for saying they're less oxygenated. They don't have enough oxygen in their lungs as they usually do. You might see their lips or their tongue swelling, and they may have hives. So this is an image kind of depicting some of the symptoms that someone with anaphylaxis might have. So if your friend or somebody starts maybe appearing like they have hives or having some of these symptoms, you can ask them, do you have an Epipen? Which is a really quick way to see if they do go into anaphylaxis or have a history of going into anaphylaxis, and also killing two birds with one stone, seeing if they have it, where they have it, so you can get that as soon as possible. Another way you can kind of get to that same question is asking if they felt like this before. If they've had any of these symptoms before, this likely is the same thing. So how can you help? Some questions, if you see someone going into anaphylaxis, you can ask them, are you having an allergic reaction? Likely they'll know. And should I call 911? If they're already in later stages of anaphylaxis, you should call 911. You can ask them, do you have an Epipen or have you felt like this before? Kind of like we talked about. You can ask them what they are allergic to. And this is super important because you're going to want to know their entire history of what they're allergic to. So like when the EMTs come or when they go to the hospital, you know what medications they might be allergic to or other things in the environment. You should ask them if you can get their Epipen, and if it comes down to it, do they need help administering their Epipen? Another thing, when you ask what are they allergic to, thinking about this now, if they're allergic to bees and you're outside in the environment, one thing that you can do to help is remove a bee stinger. You can do this with like a card or a credit, something like that, a hard flat surface to remove a bee stinger. And you want to remove them from whatever environment might be causing an allergen, like if they're outside and it's pollen, maybe move them into an indoor AC area. And some other things you can do, call 911, BCPD. This is always a good step to go, just to be safe and make sure that you have help there in case things go south quickly. You want to situate the person so they can comfortably breathe. You can help administer an EpiPen if necessary, and we'll go over how to do that in 1 second. And you can also treat for shock, which is the image in the upper right-hand corner, by wrapping the person in the blanket, keeping them warm, and keeping their feet elevated. So how would you administer an EpiPen? The 3 pictures on the screen are kind of what different versions of Epi look like. You can see the AviQ form. Some of them talk to you, which is kind of cool and super helpful, especially if you've never administered one before. But all 3 are something that somebody might be carrying if they have an allergy. So what you're going to do first is pull off the safety on the top. So that's the little blue part. The AviQ, you kind of like slip it out, and the little gray part on the one on the far left. So you pull off the safety. You're going to wrap your hand around the ejector. So you don't want to touch either end. You want to wrap around kind of like that. That's so you don't stick yourself, because that would not be fun. You're going to press it into the the outside upper thigh until you hear a click. You're going to hold the injector there for 3 seconds, remove it, and then rub it for 10 seconds to make sure the medication is thoroughly in their muscle tissue. So after you administer an EpiPen, your friend, whoever you're with, they're going to the hospital. You should call 911 likely before you administer an EpiPen, but just want to emphasize that, like, if you're going to administer an EpiPen, it's a serious situation. Do not handle it alone. Call EMTs to transport to the hospital. Epi can wear off within 15 minutes, and if you don't have a second dose, that might be super necessary, and you want the resources there as soon as possible. And Epi actually, it's a super cool drug. It mimics a sympathetic reaction, so a stress reaction, but you want to get your patient to the hospital as soon as possible so that they can have some more advanced drugs that doctors may have. But 420 BCEMS, we are here super soon, so if you call us, we'll be there with the Epi and we'll be able to take care of your friend as soon as possible. Does anybody have any questions? And if not, that's okay. I have some links right here. If you want, you can pause the video and click on them and look into more. That's it.
Thank you, Bridget. Next will be Teresa.
Hi, I'm sharing the screen right now. Okay, so I'm going to continue, but if it's not showing, let me know. So my crash course is on bleeding control. So the first step is always ensure your safety. I think someone mentioned it before, but always prioritize your safety over the patient's, because you don't want to be the second patient on scene. And if possible, try to use BSI, which is body substance isolation. And the most commonly one used by like BCEMS is gloves. Let's see. Yeah. So there are ABCs when it comes to bleeding control. A is alert, B is bleeding, and C is compress. So A, alert. First, always alert the authorities. Either you call the 911 or tell someone specific to call the 911, because due to bystander effect, a lot of people tend to think that like other people will take initiatives and no one ends up doing anything. So make sure you're direct about these commands. And so B is now bleeding. So when you encounter the patient, never fixate on the first injury you see. assess the patient for life-threatening bleeds, and if the victim is lying down, check for bleeding under them because they might have more life-threatening bleeding that wasn't really obvious at first, and then remove or cut clothing around the wound. So now we're going to talk about compress with different situations. So first, if there's no trauma first aid kit, what you can do is first take any clean cloth like your shirt and cover the wound. If the wound happens to be large and deep, you can try to stuff the cloth down into the wound, and that will be painful for the patient, but try your best to do that and keep them still. And while doing so, apply continuous pressure with both hands directly on top of the bleeding wound and push down as hard as you can. And you can hold the pressure to stop the bleeding until other medical responders come and you're relieved. Yeah. And then second situation is when you do have a tourniquet, which can be used to control life-threatening bleeding from an arm or leg. So what you do is first you wrap the tourniquet around the bleeding arm or leg about 2 to 3 inches above the bleeding site, but make sure to never place the tourniquet onto a joint. Always go above the joint if that's the case. And then second, pull the free end of the tourniquet to make it as tight as possible and secure the free end. Then you can twist and wind the windlass until bleeding stops, and secure the windlass to keep the tourniquet tight. Make sure you know the time the tourniquet was applied. You can also mark the victim's forehead with T and the time of application. This is really important when the patient gets transported to a hospital and the doctors want to know when the tourniquet was applied on the patient. And then the third situation is when you do have trauma first aid kit, but a tourniquet is not available, or there's life-threatening bleeding from neck, shoulder, groin area where you can't really necessarily put on the tourniquet on those locations. So first you open the clothing over the bleeding wound, wipe away any pooled blood, then you pack the wound with bleeding control gauze. But if you don't have this, you can also use plain gauze or clean cloth. Then again, you apply steady pressure with both hands directly on top of the bleeding wound and push down as hard as you can. By doing that, by holding pressure, you can stop the bleeding, and then you can maintain the pressure until, again, relieved by other medical responders. So this is the overall steps that I explained. So first, ensure your safety. Then look for life-threatening bleeding. Then ask yourself if trauma first aid kit is available. If not, then you can use any clean cloth to apply steady direct pressure directly on the wound. And if there is a trauma first aid kit, then locate where the wound is. If it's an arm or leg, try to use a tourniquet if it's available. But if it's not available, then you can do the same process you would do if the wound is located in the neck, shoulder, or groin area, which is packing the wound with bleeding control gauze or any gauze or clean cloth, and then applying direct pressure. That's all I have. Feel free to ask me any questions if you guys have any. If not, I'll just pass along.
Thank you, Teresa. Flora is next.
Okay, let me know if you guys can see that. Perfect. Thanks everybody for coming. I'm going to be talking about splinting, which is something that's, I guess, not super applicable to like if you're calling EMS for your friend or something, but it's a useful skill to have if you're ever like in an emergency situation where an ambulance isn't necessarily going to be on the way, or like you're like hiking in the middle of the woods or something, and you need to, somebody breaks their leg and you need to splint a fracture. And it's also just kind of a little glimpse at what we do on scene as first responders. So what is a splint? A splint is an immobilization or support device that keeps a fracture in place. And we splint injuries for a couple of reasons. It provides pain relief. If you like break your arm and have like when you move your fracture, basically, that's definitely painful. And so keeping your arm stable and like kind of the bones in a position that they don't move and bump into each other, that provides a lot of pain relief. You also just want to support both ends of the fracture to prevent movement. Also, bones are sharp, and immobilization helps prevent bones from rubbing against each other, from protruding through skin, from causing tissue damage, or from kind of cutting up blood vessels and causing extra bleeding. And it facilitates safe patient transport. So if we're on scene and we splint a fracture, that patient can go in the ambulance and kind of be driven down a bumpy road and not cause any more damage. There's a couple types of splints. I'm going to be talking about rigid splints, which are for long bone fractures. So that would be a board splint for an arm or a leg. There's also some flexible splints that are sometimes used in foot, ankle, or other joint fractures. We're not really going to get into that today. And then in an emergency, a splint can be made from kind of other available materials, and you can kind of be creative with what you want to use for a splint. So the basic steps are you want to identify the fracture site. So your eyes are your biggest tool here and what your patient tells you. You want to stop any bleeding using bandages. And then if there's an open fracture, which means that like the bones are kind of broken like that and sticking up through the skin, you don't want to like push them back into the patient's skin, because that causes inflammation and can cause even more bleeding. So you want to like splint it the way you found it, kind of. Prior to applying the splint, you also want to look at the uninjured extremity to kind of measure out your tools and make sure you're not going to be causing a lot of movement to the arm that's broken when you then go to apply the splint. And you also want to splint the injury in a position of comfort and avoid any gross movement. So you don't, like if you find them with their arm like that, it's probably more comfortable to kind of have them bring whatever they're, like if they broke their arm here, bring it like closer to the body. And they'll usually like, the patient usually kind of keeps their arm in whatever position is most comfortable to them, but like when you get there. You also want to not just keep the kind of upper and lower parts of the break in a stable place, but you want to also control the movement of the joints next, like neighboring to whatever bones are affected. So if it's something in your lower arm, you want to keep the elbow immobilized as well, because if the patient starts moving their elbow joint, then that bone's going to move as well. You also it's important to know that a poorly immobilized fracture can actually cause more damage than not applying a splint at all. So you really don't want to be splinting anything if you're not sure about it, or if you're not in a situation that absolutely requires it. Yeah, so that brings me to the next point. If you've called 911 or an ambulance is on the way, you should wait to splint a fracture, because EMS has specialized equipment and training that they can use. But say you're in a situation where EMS is not readily available. We're going to kind of go through how you would splint a fracture. So the first thing you want to do is you want to check what we call CSM before and after splinting. So that's circulation, sensory, and motor, which is just to make sure, like kind of to get an assessment of what we're going to say for the sake of this presentation, it's an arm, what their arm is like before you touch it and before you apply splint, because the worst case scenario is you try and splint their arm and you make their injury worse. So circulation would be you're checking a pulse here. You can also check capillary refill time, which is just if you press on your finger and you see kind of the blood drains from the finger, and then when you let go, it comes back. And that time should generally be less than 2 seconds. And that's just another way of checking circulation. Sensory would be, can you feel this if you touch their fingers, and you can touch a certain finger and have them look away and tell you which finger they're touching. And then motor is, can you like move your hand? Can you wiggle your fingers? You also want to place the hand in a position of function or of comfort. So that's like if the patient were to kind of, for whatever reason, be stuck in the position that you're splinting them in, you don't want them to be splinted like that or whatever, but like you want like a functional position, like holding a cup, something like that. So you want to splint it like that. Yeah, so we already said immobilize the injury. You want to tie your knots tightly so that there's no real movement, but you don't want to tie them too tightly that you're cutting off blood flow. And yeah, you also want to use lots of padding. You don't want to really tie any knots on the injury site. And when you tie your knots, you want it to be under the board. And yeah, just remember that the goal is to prevent further injury and to prevent any movement. So some materials. Generally in EMS, when we get on scene, we have triangle bandages, cravats, whatever you want to call them. And we have this thing called a SAM splint, which is like a bendy, like moves around. Or we use board splints, which is just a piece of wood with like padding on the outside. In an emergency, you can make a splint from other available materials. There's like wilderness first aid classes that teach you more about this, but really anything that's rigid and that like, and any like t-shirts or whatever that you could use instead of a triangle bandage generally works. Yeah, so here's some examples. They used hiking poles. You can use cardboard, tree branches, whatever. Just make sure it's padded well. And okay, so we're gonna go through it a little bit. So the first thing you want to do in immobilizing the fracture is kind of measure out the splint, make sure it fits, and you're using kind of materials that are the right size. Then you want to be in that position of comfort. So not like this, not like that, like comfortable. And then here, this picture, that's like assuming the break was in the middle, you would splint above and below the injury site, and not on wherever the break is. And then, so that's like kind of a mid bone fracture. And then here, this would be if the wrist was affected, you could splint there, like you could tie the cravat on their hand and kind of down here. And then notice how the knots are underneath the board and not on their skin, because that is like not comfortable at all for the patient. Okay. And then, so once you have kind of the board attached to their whatever bone you're splinting, you want to sling and swath the injury. So the sling, you make like a little knot in the corner. You put that on the elbow, and then you wrap it around their arms, and then tie it behind their neck so that it's kind of in there like that. And then, yeah, you want to, this thing is called a swath, which is just to keep their arm when it's here like this, to keep it from moving outward. So like ideally, if they like stand up in this position or jump around, their injury wouldn't move at all. That's your kind of your goal. Okay, so here's some other fractures. The way we would splint an elbow is you could use 2 boards or like the SAM splint, like open it up and then kind of go like that. And then again, kind of tying it so that you're not directly touching the elbow, but kind of immobilizing above and below the injury site. Then if they have a shoulder, clavicle, or scapula, you can just do a simple sling. And then humerus would be the same thing as here, but on the outside. And okay, yeah, so finally we're gonna finish with some examples of how not to splint. So this first image that would be not a position of comfort. That's like super uncomfortable for the patient and can like cause even more damage. The second one is, this thing is super flexible, and like opening it up like that is not gonna do anything for immobilization, and also those knots are pretty loose. I don't know if you can tell that from the picture. The next one again is that's not immobilized at all. You can still like move around, and then yeah, the third one is just not doing anything either. So thanks for listening, guys. Let me know if you have any questions, but if not, we'll move on to the next presenter.
Okay, I am the last one, I believe, and so
I'm trying to stop sharing screen. Sorry, Stephen.
Yeah, no, it's fine. I can stop
Okay,
yours
thanks.
anyway. Okay. So mine is about environmental emergencies, specifically hypothermia. Oops, sorry. And so, yeah, this should be rather short. So we'll be done in a few minutes. So hypothermia, first we're going to start with frostbite, which is, I'm going to talk about a few classifications of hypothermia in a minute, but this is really kind of one that isn't severe enough to fall in those categories and is really more of just frostbite can have different levels, but here we're really just talking about like a superficial in frostbite on your finger or thumb or something, or your toes, like an extremity like that. But if you're unsure about the degree of frostbite, say you have your finger and it's like really purple and you can't feel things, like your best bet is always to go see a doctor, go to the hospital rather than trying to treat it yourself. But let's say that you just have been outside a little bit too long and you realize that your finger, you can't feel it as well, but it's not too bad. And then, it's still always best to consult a doctor, but just as far as rewarming superficial soft tissue hypothermia injury, you just want to remove all clothing and jewelry. This will be the same for every type of hypothermia because that way you allow more blood flow to the area. You want to make sure the injury will not refreeze. You don't want to warm it up and then have it refreeze. So like, let's say you're outdoors and it's still really cold and you have like some warm water. And so you think you might want to try to warm it up. Unless you can be certain that it won't freeze again, you don't want to start the warming process. If you're sure it won't, then you can just put your extremity in a warm but not hot water bath. You want to keep ensuring that the water stays warm, whether or not that means bringing in more warm water or stirring the water to make sure it doesn't turn cool. You just want to make sure it stays warm, and you want to continue until the extremity is soft and color and sensation return, basically until it's back to normal. And then you just kind of want to dry it and dress it with dry and sterile dressings. And again, if let's say you start doing this and it doesn't get any better, then you should call your doctor or go to the emergency department. And then for worst types of hypothermia, there's 3 categories right here: mild, moderate, and severe. And these are the approximate core body temperatures which go with them, which really you're not going to necessarily be able to get because it's hard to take a core body temperature, and peripheral and core sometimes misaligned. And so really the symptoms are the better indicator of which type of hypothermia someone's in. And so for mild hypothermia, there are symptoms such as shivering, poor judgment develops, amnesia and apathy, increased heart rate, increased breathing, cold or pale skin. So basically somebody who is kind of just a little bit out of it, maybe their heart rate's increasing, they're starting to breathe harder, they're shivering. You can tell they're kind of cold, but they're not necessarily to the point of being moderate or severely hypothermic. Moderate hypothermia, progressively decreasing levels of consciousness and stupor, the shivering stops, decreased heart rate and breathing. And so in mild, it's increased heart rate and breathing, whereas in moderate, it's decreased heart rate. You have decreased reflexes and no voluntary motion, paradoxical undressing. That kind of goes along with the shivering stopping in terms of paradoxical undressing, which basically means that these people have hypothermia, but they're taking their clothes off. What happens is they feel so warm because their senses get all messed up that they start trying to undress even though they're freezing to death. And so that's a sign that somebody's really hypothermic. And then severe hypothermia, which you can see the core body temperatures for this are really low, would include symptoms like low blood pressure and bradycardia, which is slow heart rate, no reflexes, loss of consciousness, coma, death. So that's the really bad form, obviously. And so treatment of these for mild or moderate hypothermia, you want to change the environment. So if you're out in the freezing cold, you want to get them somewhere that's warmer. You want to cover their skin with warm clothing or blankets, stuff like that. You want to first remove the wet clothes, and so they don't continually get colder because of them. Give simple carbs or like juice, just something to warm them up and give them some sugar and energy. And then you want to warm the patient. So that kind of goes along with changing the environment. But it can also take other forms like administering heat packs and things like that. For severe hypothermia, you want to handle these people really gently, because if you have severe hypothermia, a lot of times you can have cardiac abnormalities, and if you move them without being gentle, you can send them into even worse rhythms that can lead to cardiac arrest. Warm patient, evacuate immediately. And like we said, with severe hypothermia, sometimes they go into cardiac arrest. And so in that case, you would perform CPR. This just kind of goes over what I talked about, whereas there are the different levels of hypothermia and just the steps you want to take as far as like reducing heat loss. Like if they're not hypothermic yet, they can move around. Mild hypothermia, you still want to handle them gently, give them heat, something to eat or drink, monitor them. And then the steps keep going. This wrap is something that's like specific to the people that make this instruction thing, but it kind of shows the idea that I was talking about, whereas if you have wet clothing on, you want to remove that. And then this is an example of something that you could wrap somebody in to keep them warm. And then as far as when we were talking about warming the patient, you want to, if you have heat packs or even things like a warm towel, things like that, you want to put them in the neck, groin, and chest area. You want to keep it around their core, because if you put it in their extremities, that will cause the cold blood that's in their extremities to go back up to their torso, which will cause them to become even colder, which is not what you want to do. Wrap the patient in warm blankets and maintain a warm environment. The recommended rate of active rewarming is between 0.5 and 2 degrees Celsius, 0.9 to 3.6 degrees Fahrenheit per hour, which again, those are hard things to measure and keep track of. The general idea is that you just don't want somebody to be rewarming too quickly. You don't want to rub the affected area, because that can cause problems with as far as like tissue damage and nerve damage. And then remove tight clothing or jewelry, like we were talking about earlier, to ensure that blood flow is not compromised. And so, yeah, that was pretty quick, but the general ideas are just take any clothing off that's restrictive, get them out of the cold, wrap them in warm sheets if they're really hypothermic, get hot packs on them if possible. And then, of course, you know, if you're in a situation like that, you want to be calling 911. So, yeah, I'll stop sharing. If anybody has any questions, you can ask, but if not, I can end, or I don't know if Bridget, you want to end the meeting because you have, you're recording it, but.
No questions? All right, I'll press stop on recording.